Vaccine distribution has begun in just about every county in the Bay Area, but there's been a few issues. This is the Rebound Tampa Bay podcast. I'm James Tully. Let's get the perspective of somebody who sees COVID patients every single day and has already received both doses of the vaccine. He's Dr. Jason Wilson, the Associate Medical Director for the Emergency Department at Tampa General Hospital. I had Dr. Wilson on the podcast just a couple of weeks ago. We had a very detailed discussion on the vaccine itself, how it was developed, what exactly it's going to do when it's inside your body. And today I want to spend some time talking about not just the distribution and where we go from here and when you can expect to possibly make an appointment to get a vaccination regardless of your age, but I also thought it'd be a good idea to dispel some of the myths that are floating around about the vaccine, and who better to talk about it than somebody like Dr. Wilson. If you'd like to listen to our previous podcast, I have linked it up in the description of this one. I highly recommend it if you have any questions about the vaccine itself. Okay, here's my conversation with Dr. Wilson.
Thanks for having me back on. I was on before, and I think we were talking a little bit about the vaccine rollout that was coming, and now we're in the middle of an initiation of a vaccine rollout. And let's talk about where we've been and where we're going to go with that a little bit.
So start with this. You just told me that you were able to get your second dose of the vaccine yesterday. And you said, I guess I'd be curious, or anyone listening or watching, what kind of effects you felt from that, how you're feeling today, how you felt after the first one. What can you tell us about that?
Yeah, so after the first dose of the vaccine back on December 15th, the next day, I woke up and it felt like somebody had punched me in the arm. And that lasted for about 2 days. And it wasn't anything, serious. I'm left-handed, so I got the shot on my right arm. So I was able to do all my normal, activities. And it didn't really affect me, just a little sore. And that was it. There were no more side effects. And, what we do from the studies, the clinical trials, is that on the second dose, people may have some more what we call systemic effects, meaning maybe some more inflammation, because now you've really ramped the body up to produce inflammatory responses to COVID, to the spike protein. And so we knew from the studies on that second dose of vaccine, some people had some more side effects, but they were still very minor. And what do I mean by that? Well, I think I'm having them. And what that means basically is my arm is sore again, and I've got a little headache today. I'm right now about 26 hours post-vaccine. I just took some ibuprofen. The headache's going away already. I was a little sore today, maybe a little bit more in the first one, but really, not anything more than when you're getting over a cold or the day before a cold, that kind of just, I don't feel super great today, but really not a big deal.
Minor. All sounds very minor. Pretty much what was expected when you were on the last time, and we basically broke down and did Vaccine 101, COVID-19 Vaccine 101. That's right. This is basically what you were expecting to happen, and that is what's happening to you. And as we move forward here, the vaccine rollout is happening. It is in effect right now in pretty much every county in the Bay Area. It's been a staggered rollout. Can I get your opinion on how you think the rollout has gone so far, both good and bad? How do you view it? How do you break it down?
And, I'll say one other thing about side effects, too, as we transition on. And that's, we've now, I know of, thousands of people, over 7,000 people in our hospital system now who've been vaccinated. And we haven't had any serious adverse events. No one's been put in the ICU or had anything, that was more than Tylenol or a Benadryl happen to them. So I just wanted to say that, too, from personal
much better sample size than just you, for sure. Well, let me ask you this. How are you approaching life now at home, maybe with friends or anyone else that's vaccinated? Are you breaking the social distancing now? Are you kind of approaching this like before the pandemic hit?
No, it's too early, and, I a friend of mine said yesterday, wow, you're the first person I know who's had 2 vaccine doses. So I'm kind of on a boat of my own still right now. And the last thing I would want to do is get somebody else sick. Because remember, from the trial, it was still possible to have asymptomatic COVID, just not to get sick from COVID. So I would hate to have COVID and get somebody else sick during this period of time.
I want to talk about that a little bit later, too. I want to get into that. Moving forward, when we do have a large amount of the population in the country, in Florida, vaccinated, how do we move forward? Right, I want to get to that. But the rollout, the distribution so far, there's been some frustrated people. We've so far had healthcare workers, majority of them, and now we're trying to get the senior 65 and older vaccinated county by county. Look, the rollout's been clunky in some ways. And admittedly, from officials, it has been it's been a process. There's been tied up phone lines. There's been online application systems to get your slots to go in and appointments been backed up. What are you seeing from your end, and what's your overall viewpoint on it?
Sure. So first of all, I completely understand the urgency that people have, and I'm actually very pleased to see that people have urgency about getting this vaccine, because that means we're in a good space in terms of people wanting to be vaccinated. And we always worry a little bit about vaccine resistance, or deciding not to get the vaccine. But I think people have seen that the science is really good here. They've seen, leaders in all kinds of fields and from every political party willing to take this vaccine. And so at least we know that people are going to be willing to get this vaccine when it's available. So that's one thing that I think is promising. And then the other thing, this urgency that comes with it, I understand. The bottom line is that every day that goes by where there's shots on shelf and not shots in arm, that's more hospitalizations and more deaths. There's no way around that. We know that after that first dose of vaccine, after just 10 days, you decrease the transmissibility by 50%, by half. So that's half the people who get that first dose of vaccine who would not get COVID now. And then that second dose, as you mentioned early in the program, we're down to almost not getting sick from COVID, 95% decrease. So, I understand this is a lifeline, and this is the way we're going to get back to normal society at some point here. So I get the frustration, I get the urgency. Now, the other side of that coin, which I think is a little hard to recognize during this, is that healthcare systems are having to do something they've never done before. Right, this time that I've been asked to stand up a mass vaccine distribution campaign in my medical career, and it's kind of like having young soldiers, right, who've never seen war combat for this specific type of war. Some getting used to it. We're trained to do it. We have the medical knowledge to do it. If you go back to March and think about how many operational processes we've stood up at record-breaking time, I think about the medications we're using now, especially the monoclonal antibodies, those infusion meds we give as outpatients. That's a transition of care type of healthcare system, drug delivery we've never even seen before. And so it's going to be a little clunky when we stand a process up like this. And, the way we had to distribute vaccine with Pfizer, it's, as we mentioned before, it's a negative 80-degree stored vaccine. So that limits where the vaccine can go. So you end up with these central vaccine distribution centers like Tampa General that then works to move those out throughout the community. Well, that's a little bit different than what we've done before, too. So now Tampa General starts to move drug to other healthcare systems, Baycare, Moffitt, wherever else in the community, to make sure that people there can get vaccine as well.
And that's a process, too, Dr. Wilson. I mean, this isn't like delivering a hot pizza to your door. Right. You can't just put this in like a special container. I mean, it's a process to keep it at that minus 80.
Once you take out that minus 80, you've got 5 days to use it, and no one wants to waste this vaccine. To coordinate, okay, I'm going to bring them X number of doses. They get 5 days to use it out of the freezer. Well, what about dose number 2? Are we planning for dose number 2 at that community site or that other, partner organization as well? So there's just a lot of moving parts here. But, what you're seeing, again, this has been throughout COVID. What you're seeing are organizations that really never had much of a reason to do a lot of things together have to now come together and do. And so you see the Department of Health working with the hospital systems, working with the state government, trying to figure out how to make sure vaccines coming down from the federal government, how much we need, where it's going to go, how do we distribute it out to the community. And so what you've seen is people standing up processes, vaccine clinics, and it kind of makes sense to test this first or to use this first in that first group. There's the first group of those frontline healthcare workers, and now there's that executive order as well. And so we've seen us kind of use the stuff we have built in from an infrastructure standpoint and try to exhaust that knowledge base, right? So I can give it to my frontline healthcare workers in a hospital. That's pretty easy. But how do I get it to a long-term care facility, or a person doesn't really have a relationship with our hospital, or to a person who's homebound at home and is elderly in that first group? These are the kind of issues we're trying to solve right now.
What are your thoughts? I mean, we're just a few days into 2021. Could you give a grade on how things have gone, at least from your perspective over at TGH with distribution?
Sure. So I think where we could have done better in the future is the pre-planning from that federal government side of things, from like knowing this problem was coming, knowing we're going to have to face this issue. How do we actually? And people thought pretty well about how to move vaccine to the state, but it's called that last mile of shot to from the state to the arm. How do we really kind of focus on those weeds? And those are weeds, and it's tough to get into the weeds of that type of an operation when it's the same people who are also treating COVID patients and setting up processes to manage COVID patients in hospitals safely. It's that same group of kind of operational experts in healthcare who now have to kind of move over to this problem and start to solve that. So I think that's probably where we could do better in the future is, another way to say it is I think what we've seen exposed a couple of times in this pandemic is our underlying public health infrastructure. We do have we've been called on it. We've definitely been called on it. We knew that the CDC is the most respected, organization across the globe in terms of disease recommendations and health recommendations. And we have, some of the smartest people working on public health. But when the dollar hits the door, or whatever the right analogy here is, we kind of realize there's some holes and some gaps there we're going to have to go back and solve. One example of this is the Department of Health. They were asked, they're already a very tasked organization, your county Department of Health. They're asked to do a lot of things. STD testing, making sure the population's safe, the water's safe, all these things that they do on a daily basis. And then they're asked to start doing contact tracing for these thousands and thousands of people who are testing positive for COVID. It seems
impossible.
It seems impossible. And they're asked to stand up a testing site. And now they have to come up with a vaccine program too. So it's just, a lot of moving parts there of trying to find the right, blend of how we get staff over here when staff's kind of doing this thing over here.
And Dr. Wilson, people are still scared, if for example, our morning show, our news program, we have to every 15 minutes, we make it a point to update people on what's happening with the COVID-19 cases in Florida with a lot of context, mind you. We don't just throw numbers, big red numbers up on the screen, but let's be honest, that's the most important part of our jobs during a pandemic is to keep people posted on how things are trending. I think that's just us doing our due diligence. But in response to that, people see that every single day, and that, I know you said you feel great about people wanting to get the vaccine, and you're seeing that desire to get it, but at the same time, that's one of the reasons, I think, is that people it's reflective of the news that they have consumed every single day for the past 10 months.
And that's that urgency I talked about. And I don't mean to belittle it by this analogy, but it's kind of like the new iPhone. It's like we never had an iPhone before, and the brand new iPhone comes out, and it's at the Apple stores, and you have to, the lines are going to be huge. The way you order online is going to be huge because we've never seen this before. And I don't mean to belittle that because this is not an iPhone. This is a life-saving vaccine. And so there is deserved urgency for people to want this vaccine. But what I think is going to happen, James, is that, a couple of weeks from now, as we stand up each process, they're going to be stood up. They're going to exist. And they didn't exist before. So, I said a couple weeks ago, it's hardest to go from 0 to 1. So we did that. We went from 0 to, we gave first vaccine. That's great. Now we're kind of going from 0 to 1 to 2 to 3, and then we have to exponentially grow that 4 to 8, 8
that's
to 16.
That's a great way to look at it.
Right, and that's just and it takes a minute for an exponential growth curve to take off like that. You're going to have a little bit boop 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 boop, and then you start to accelerate the car.
And how many doctors for the first time in their careers are doing something like this? During a pandemic where, like you said, a masked distribution where you have to be really careful there, and everybody's. I mean, you're trying to get 85% of the population vaccinated in a year. So that's all new territory for everybody. And I like your iPhone analogy, except it's as if you didn't get the phone, you'd have to go back inside your house and wear a mask.
Because I recognize the phone is fun. I recognize.
But it's comparable. It is a very desirable thing, and as a result, phone lines get flooded. People are lining up. There's some tensions in lines and things like that. I think it was all to be expected, but it's happening in real time now. There's of course a lot of good things going on as well. I mean, I know the numbers. The Trump administration's goal of 20 million vaccinations by the end of 2020 didn't happen, but I think just just to get any vaccinations before the end of the year, at least from my perspective, was a step in the right direction. I mean, I know you feel the same way. You called this vaccine a modern medical miracle the last time you were on the podcast here.
Yeah. Yeah, I still go back to the fact that, a year ago I was learning that this virus existed. It was on, I can always remember the night, it was a Sunday night in February, late February, when our hospital infectious disease doctor came and found me on a clinical shift in the emergency department. That's never good when your head ID doctor, infectious disease doctor, comes to find the ER doctor. That's not what you want to have happen. So something's up. And I remember we went aside and we talked about that the first cases had shown up, here in Florida, the people who had come back from Italy on a vacation. And, we started to plan this out. That was not even a year ago. That was 10 months ago. And we've sequenced the virus since
Dr.
then.
Wilson, what kind of concern did he have at that time when you guys had your conversation?
Oh,
really concerned?
yeah, it was concerning. And I think, the tension and concern from, look, there are two people who do not get nervous very often are emergency medicine doctors and infectious disease doctors. We're kind of built that way, right? I mean, our infectious disease doctors seen Ebola cases and, seen, all kinds of other, these life-threatening viruses.
Let me chime in. We like it like that. We don't want you guys to get nervous very often. Yeah. Yeah, right.
Right. So, I think we went to work right away. We really did go to work right away that night. I remember we basically started doing what we were trained to do, which was, okay, we're going to have a pandemic. We know how to do this. We've trained to do this. You operationalize a mass triage system. You operationalize mass disaster protocols. You start to figure out how you're going to treat people the best you can. You could start to figure out if there's going to have to be some compassion treatment or not if things get very bad. And you start to watch, what's going on globally, and start to pay a lot of attention. All of a sudden, I was, listening to CDC phone calls and, going to a lot of DOH meetings.
We mentioned this COVID-19 variant every morning. It's first discovered in the UK. Layman's terms for variant. Is mutation safe there? Because variant's just not a word that we use often in daily conversation. So when we talk about a variant or a change in the virus, what's the best way? In layman's terms, Dr. Wilson? Yeah. What's the best way to explain it to somebody?
The way I think about it is we all have smartphones, but some of us have variations of the smartphone. Some of us have an Android and some of us have an iPhone. Right? We're all human. Some of us are tall, some of us are short, but at the end of the day, we're kind of all human, right? And so this is the same thing. There's some genetic differences here. What we see so far is that those genetic differences don't affect too much about the way we're targeting this virus therapeutically, meaning the way we want to go about vaccinating against and treating this virus, it doesn't seem to really affect that. It also doesn't seem to really affect how sick people get, which is great news, right? So what we think so far is that at the end of the day, the little piece of RNA in this virus is going to make the same machinery in the human cells. It's just going to do it in a slightly different. It's like a different set of directions to build the chair. You still build a chair at the end of the day. And you can get different instructions for the chair from IKEA, but you're still going to build the chair at the end of the day. Yeah, right. That's right. IKEA. So, yeah. So what is very fortunate right now is that there is no evidence at all because we talked about this before. This little guy called spike protein has become very important medically, and that's the little protein on the surface of the virus. And right now, all of our treatment modalities really target spike protein, and our vaccines target spike protein. And spike protein, the reason why it's important is what it does. It's like like when a spaceship docks on the space station. It's like the little bridge that docks on the space station and lets the people come into the space station, right? So it's like the pathway in. So spike protein binds to a human cell and lets all the little machinery of the virus come inside. So fortunately, that seems to be the same. Now, the concerning thing about this, and we're not sure about this, I want to put that out there too. What we are concerned about right now, the reason why you're seeing such an aggressive approach from the UK and from other public health experts is that there is at least some modeling data. Like we're kind of mathematically saying, wow, this person seems to have gotten the variant and this many people got the variant around them. It kind of looks like maybe more people than we would have expected got COVID from this one person. Now, the sample sizes are still pretty low because remember, we've had cases of normal COVID the normal COVID variant where like one person in a restaurant infected like the whole restaurant, or a wedding infected like the whole wedding. So, but the average for a COVID, for the normal SARS-CoV-2 is that each person who gets it probably will infect 2 to 3 people. That's if you're not doing all the social distancing measures. But if you just kind of go out there, you might infect 2 to 3 people. This one, you could say, well, perhaps it actually would cause you to infect about 50 to 70% more people. So the problem here, the concern here is that suddenly instead of 2 to 3 people you may infect 3 to 4 people. And that may not seem like a big deal, but remember, we're talking thousands and thousands of people of the virus. That's one extra person for all those people. That adds up.
It would be like double the number of cases that we see every day, and that would be that's a pretty. So
that's the concern right now, and we don't know for sure yet, but that's what it might look like, and that's why people are taking this seriously at the moment.
Okay, well that's the variant, and can you give me a level of concern where you guys are with that in Florida? Now you mentioned the UK. Now they recently issued some shutdown orders, some lockdown orders because of this. You mentioned that they're reacting pretty swiftly. We did have our first case in Florida. I think it was Martin County. Don't hold me to that. So it's not in our general vicinity here in the Bay Area.
Well, and James, I would offer it. It probably is. If we find it in Martin,
this is just the way the virus. I know exactly. I got you.
Yeah, and this is important. We think about should we have closed China earlier or not closed China earlier? Should we cancel the flights in the UK or not UK? It's key for people to understand that what isolation of geographic areas do with viruses, it holds them off a little bit longer, but eventually that virus is going to make its way to our population too, because viruses don't care, which county you live in, right? They like Hillsborough County just as much as Martin County. So it's probably here. We just probably haven't identified, a genetic sequence.
Well,
of
let's just
yet.
get it out there. You do not think that this is any more the medical field is not believing this to be any more deadly, just more contagious.
Correct. Yeah. So far, there's been no evidence presented or anything from the CDC or WHO or any organization, public health experts that says this is the term is virulent, meaning how sick somebody gets from the virus. This is not any more virulent than the other variation we already know about.
And again, when this does come, the vaccine, and you're vaccinated, it seems to be in line with something that is can fight this mutation.
Yeah, unfortunately, this just amplifies and intensifies our current recommendations we already have, right? So if you're going to infect another person, 50 to 70% more people, well, then it becomes even more important to please do all the social distancing measures, right? Because now you are potentially even more infectious with that virus. And then, of course, to let this vaccine campaign roll out as well.
We talked about the top words of 2020 that we want to banish. I think Oxford puts that out every year. Social distancing, COVID-19. I forget. There was a couple other ones. Get through it.
Yeah, well, what I hope actually happens from all of this is that we go back and we learn what worked and what didn't work.
Yeah, you mentioned that last time, and I think you were really open and honest about that, and believe me, really appreciative on this end, because you mentioned a couple of things that that I saw happen at the beginning of this pandemic, and I thought, I don't know if that's necessary. And I think there were a lot of things that felt like scolding the public that I think frustrated some people. You mentioned shutting down parks. I mean, I was out here walking my dog, and I watched looked like a couple of friends. Maybe they were brothers, maybe they weren't. But they had a basketball, and they went up, and the basketball rims had been taken off. And I'm thinking, really, is this where we are? Is this a necessary thing at this time? However, it was admittedly a little earlier in the process. I know we need to be cautious and everything, but you were very open about that. You said we need to go back and assess the things that we did that we didn't have to do, and maybe some things that we didn't do that we should have done.
Yeah, I think the trust in the public is so much higher if we admit that this is a brand new pandemic. We are doing our best to flatten the curve and to hold it off. And, we might have been aggressive in some areas, maybe not aggressive enough in other areas. Home gatherings might have been an area we weren't aggressive enough about, we've learned over the holidays, versus outdoor dining and outdoor parks, or outdoor reasonably sized gatherings. I don't see a lot of infections come from those places. And it's somewhere where we have to take the clinical reality and be true to it and be honest with it. And the reason for that is because I do support using public health measures to protect the public, and I want to be able to use those tools again in the future with public trust that we're making the right decision. We're doing the best we can given the data we have, not just reacting when we have evidence we don't need to do something.
Talking about getting back to normal as we move forward here, you said the goal, I think you told me on a previous discussion that, we're looking hopefully late spring, early summer, where there's enough of the public vaccinated. There's a number that I think Dr. Anthony Fauci had mentioned. He wanted between 70 and 85% before any kind of mandates are relaxed. You concur with that?
Yeah, it's going to be a flu. This is one thing that's, I think, very interesting is the public has seen us do science in public, and and sometimes people will say, well, didn't he say that he wanted 60%? Now he says 90%. Does he want 60% or 90%? And does he want us to wear a mask or not wear a mask? And what you're seeing is this is how we operate as scientists. We get new data and we try to modify our best hypothesis. And so you're going to see this number move around a little bit, and it should move around a bit because the transmissibility starts to change as you get more people vaccinated and more people have immunity to it. And so it seems reasonable, right? It's a great goal because it gets us moving towards a mass vaccination strategy. And that's the key, I think. What we want to demonstrate is that our goal is not to withhold vaccine from the public. Our goal is to get vaccine into arms. And I think that's part of that focus is whether you say it's 100 million shots in 100 days, 1 million shots a day, 90% of people. But I think the goal is to get as many shots into as many people as possible. And I know look, I mean, my family's been blowing up my phone too, because I told them all about the website it could go on, right, which, didn't work. And again, the Apple site doesn't work either when the iPhone comes out. It reminded me of Nirvana tickets in the 90s on Ticketmaster or something.
Well, for you, it was Nirvana. For me, it was Blink-182. But nonetheless, it's been a while. Yeah.
Yeah, it's been a while for me too, but it was that process, sure. And it kind of reminded me of that. But again, I don't mean to be little because I recognize this is a life-saving medicine. But start to see is a rapid scale up of this. The first thing we're starting to see already now is that healthcare systems that have vaccine, including Tampa General, have started to open up that vaccine to the community in some ways. And what I mean by that, so for example, the Tampa General system, which has like 15 clinics throughout the area, has started to let their primary care docs, use the vaccine to vaccinate those who fit this is important to understand too. We're under an executive order we have to follow. And so the governor's executive order right now says that it's, for frontline healthcare workers who treat COVID or who at least have encounters with COVID patients, as well as people over 65 or people who have, medical comorbidities. And so we have to follow those rules. But otherwise, we're starting to, now that we've got a lot of frontline healthcare workers vaccinated at most of the major hospital systems, at least, we're starting to see the availability of who can come in and get vaccinated really start to expand. So Tampa General started doing the primary care clinics and then just opened up to family members. I actually was finally able to get, grandmas and grandpas and people in my family, appointments for a couple weeks from now. And the Bay Cares are going to do that, and HCAs are going to do that. And and then DOH, like you mentioned, has, we'll work through this, and their website will work eventually. And I saw the county commission is going to make some announcements about some improvements there. And I can guarantee you 2 weeks from now, you're going to see more mass testing sites. You will see that. And you're going to see more private partnerships of places that people can go and get vaccinated. I can guarantee you'll see those things come to fruition in the next 2 to 3 weeks.
Of course. And just as you talked about exponential growth and the plan for it, you got to believe you're going to see that. You're going to see more places offering the vaccine. You're going to see more doses coming in, of course. I mean, I think it's going to be immeasurable by the week, and I'm not even working in your field, and I have that. Maybe I'm just being optimistic, but I just have that feeling that a month from now, 2 months, 3 months. I mean, yeah.
Even if you look at this weekend in the United States.
Well, I was going to say, Dr. Wilson, people might be at home nervous about, when it's my turn, I'm never going to get in. I'm never going to get an appointment. I don't have that same pit in my gut over it. I really believe that there are going to be plenty of doses to go around. It's just people I've talked to, things I've read. I really feel like in a couple of months, we're gonna be in so much better shape than we are now. It's just gonna keep getting better. The doses and the places to go to get it and get people you care about vaccinated. It's just gonna be easier.
Yeah, and the evidence for what you're saying is that right now we have about 30% utilization of the vaccines that we have available.
That's it, 30%.
Which basically
means, yeah,
right. Which basically means it's just an operational problem. This isn't like it's not even it's supply problem from an operations perspective, not from a vaccine availability perspective yet, which is great because what's going to happen is as we figure out the operational stuff, then we'll start to really ramp up. And so far, we have gotten more vaccine from the suppliers. We've gotten another shipment of Pfizer at Tampa General post we got the 20,000 doses, a few weeks ago. We have gotten more after that, which is always, look, you're always a little nervous. Like, am I really going to get more? Are they really going to send more? And they did. And they did. So I think that's always a good sign too. It really is coming.
That's great. I'm ready to wrap up here. I had a couple of things I was going to ask you about. We have not talked enough about flu season. And,
Sure.
There's all kinds of things that like to get passed around on the social media websites. It's one of the reasons why I've retired from a couple of them. Keep that on the down low. But it's just been one of those years where I'm just happy to retire from checking social media all the time. However, flu season. What's that been like? What have you seen there? Can we draw any correlation between the measures people have taken, maybe combating the flu a bit, less all the social distancing, the mask wearing?
Yeah.
Tell me about that.
Yeah, let me walk through it a little bit because I'm gonna take a little circuitous route because, like you said, I've seen this stuff on social media too, and I think it's important
I do a
to at least
podcast.
broadly
We have time
address
to do this stuff. This is
Okay.
why we deep dive.
Well,
This is exactly
yeah,
it.
and I think this is an important one because I think there is some confusion around
Sure.
this. So, first of all, it's not uncommon. So, let me back up. First of all, we have not seen much flu yet in this area. I have not diagnosed a single patient yet with influenza A or B. Okay, which is great. That's great because what's great about that is that it means that our healthcare systems are not being overburdened by a twin.
That's excellent. Let me just pause real quick. In a normal year, at this point of the flu season, how many would you have expected to have seen flu patients?
Yeah. So that's great. So that's number two. So number two, it's important to understand that it is not uncommon in the state of Florida to not see influenza until late January, February, even early March. So we need to keep that in mind as well. We should still be vigilant about the fact that flu may still be coming. Now, here's something that's important, though. People get flu vaccines. There's about I may be off a little bit on the numbers, but say 50 to 60% uptake, on people who offer flu vaccine who will take the flu vaccine. So it's a reasonably, high uptake of flu vaccine, and you can check the numbers. But millions of people a year get the flu vaccine, which is great because that prevents, obviously flu cases and hospitalizations. So what we know is that it seems like about the same number of people who get flu vaccines every year are probably going to get flu vaccines this year. Great. What does that do? Well, if you take flu vaccines plus this extra public health measures of social distancing, not only should we see normal flu levels, we should see a decrease in flu levels. Now, people come back and they'll say, yeah, but you've said that sometimes the social distancing measures aren't really being held true in this state, and people are, kind of going out and not wearing masks, but they're doing it some. And so we may have some baseline level of flu. We've got flu vaccine to bring it down. We've got some social distancing measures that are happening more than we've ever seen before, right? We didn't see any social distancing measures with H1N1 in 2009, or that I can remember ever with influenza, except for maybe a person here or there. So I do think we've probably decreased flu transmission a bit as well. Now, the other important point too, the reason why infectious disease modelers sit around and worry about coronavirus, they worry about influenza too, but they worry about coronavirus because it's the SARS virus works differently. It's a very infectious virus. It is more infectious than influenza. And so it is not surprising that that we would see less spread of influenza normally than we would see of COVID. So this is it doesn't show that something doesn't work or that something does work because we see less spread of influenza than we do of COVID. We expect that based on the viral properties. It's an influenza virus, not a coronavirus. And so that works a little bit different. And we're prepared for influenza. Every year, the reason you have to get a flu shot every year is because you've got these virologist experts who kind of go through and they predict the variant. We used that term earlier, the variant of the flu that we're going to see, actually the number of variants that they think they're going to see. And they make kind of a mixture or juice that's going to be in the vaccine that year, and they take their best guess. And so we're pretty good at predicting. We get it a little wrong sometimes. That was 2009 because there was some zoonotic transmission, but they're pretty good at predicting this stuff. And so we do a pretty good job of containing flu, but we're not out of the woods yet because we could still see flu in January and February. Now, one other caveat about flu I do want to talk about. If you think that you're going to be in a vaccine group You're a good example, James.
Sure.
Maybe you're in the what I call like the purgatory land of like you're probably not gonna get vaccine this week, which is right. So you're not over 65. You're not a frontline healthcare
Correct.
worker. You've probably got a few weeks to get the flu vaccine. I'm sorry, the COVID vaccine. Now is the time for that group of people to go out today and get their flu vaccine. The reason for that is because the recommendation is that we wait 2 weeks between any vaccination. Just your body's going to ramp up inflammatory markers, so we don't need to give you a bunch of vaccines every day. So if you're probably not going to get the vaccine for another 2 weeks, go out and get the flu vaccine today. Then when that 2 week window has passed, you'll be ready for your COVID vaccine as well, and you'll be double vaccinated against the whole shebang. And you'll be in good shape.
That's great. Yeah, I got mine back in very early. I think I got mine in October, November, and I typically do. But, like you said, you're taking a lot of times it's a guess on what kind of strain you're going to have. So, you talk about people who get the flu vaccine and still get some form of the flu. That tends to happen, and you see patients like that all the time. Now, I wanted to ask you, the COVID-19 vaccine itself, we still are not sure how long this will be effective, right? I mean, is this going to turn into an annual vaccine for people, or where do we stand with that?
We don't know right now. The question is going to be about how much memory immunology is there in the body. How much does your body remember? Because here's what's interesting. If anybody has like spheres of side effects of vaccine, what's interesting is that when you get the vaccine, it's going to go, these muscle cells here are called myocytes. And the vaccine, medicine is going to go into those myocytes, those muscle cells, and it's going to make spike protein. And then those very cells in my body are going to show spike protein. And what's going to happen is that as I make antibodies, it's going to kill those cells. So eventually, those cells that made spike protein are going to go away. But my body's going to know how to make antibody against COVID virus. So the question on the table is, if we don't have the instruction booklet anymore, if we handed it off, do we have enough memory of that instruction booklet? Do we take a picture of the instruction booklet before we threw it away, or before we shredded it, that we can keep on producing antibody next year and the year after? I don't know. My guess is what we'll probably see with these mRNA vaccines. And the reason mRNA vaccines are so exciting is I think they're very much like plug and play kind of technology, like a new app update or a new firmware update, where you could probably just change the mRNA code a little bit and give a person another booster type of dose in the future if we see some change in the mRNA or in the COVID virus, or if we think that those antibody levels are dropping. So you're going to see studies where we follow people's antibody levels out over time and try to figure out if we need other doses. We just don't know the answer right now, though.
Long-term, big picture stuff with COVID-19 itself. We get 85% of the population in the United States, 85% globally vaccinated. What's the future for this virus? I mean, will it eventually be eradicated? If so, how does that happen? Do you foresee something like that, or do we have this thing floating around, and even though many people are vaccinated, the ones who aren't may still get sick from it, or it's still being transmitted, but people don't show symptoms for years, for decades?
Yeah, and that'll be part of the question is, if it's still being transmitted asymptomatically, but it doesn't matter, then it just becomes an endemic virus. Like there's a lot of viruses we don't get worried about if you get the rhinovirus, which is the common cold virus. I don't get too worried if you get the rhinovirus, and because you're not going to get very sick from it. And so if we are able to get most people vaccinated, and we know that we can keep people from getting sick from coronavirus, then it doesn't really matter too much if there's a little bit floating around out there, as long as no one's able to get sick from it in the population. Now, it's also possible it just goes away. MERS went away, and the first SARS went away. So we don't know. It is possible it could go away. When I say go away, I don't mean magically go away. I mean go away after we have 80% of people vaccinated, because now there's no place for the virus to go.
It runs course.
So we don't
people,
know,
and that's it.
Yeah, so it's either going to have a asymptomatic reservoir where it can kind of hang out with people and not cause any symptoms, which keep it around the population. Which means what that would mean is that we would just be getting COVID vaccines into the future, just like we do with a number of other bacteria and viruses. We get vaccinated, for generations.
And there'll
now
be that one stray case that we report on, in a couple of years from now, or something like that, where COVID-19 popped back up, somebody showed some symptoms or something like that, right?
Sure. And remember, it's, not a perfect vaccine, right? It's 95%. We'll still test for COVID, just like we test for malaria, when somebody comes in with a fever. It's not likely in Tampa that somebody has malaria, but if we can't figure out the reason, we might test for malaria.
Right. Exactly.
Yeah, right.
Okay. So I'm sensing you seem a lot more optimistic today talking to you, Dr. Wilson. You seem
I am optimistic. I am guarded. I am optimistic, but understanding of how frustrated and urgent people feel right now, because I really do recognize that every day that we don't get vaccines out, those are potential hospitalizations and deaths. So I don't take that lightly. But I am very pleased with how rapidly I'm watching healthcare systems stand up these processes and get people vaccinated.
I think we can leave it there. I'll give you the floor if there's anything else you wanted to touch on. Great response last time with the podcast. Yahoo News picked us up. The entire conversation, we had really terrific numbers. People got a chance to see that and hear it, which was great because, again, I said at the beginning of the podcast, I'll say it again. Go back and listen to Dr. Wilson's podcast on the Rebound Tampa Bay, and we talk about the vaccine in great detail. And really up until that moment, I wasn't exactly sure what it was and how it was produced and how it was invented. But it was a really enlightening conversation on the vaccine. I thank you a lot for that, Dr. Wilson. I really do.
Yeah, that's no problem, James. And one other thing I will add that's probably going to happen in these next few weeks or soon is we'll probably see other vaccines show up out there and be available as well. With other technology. So I think we're getting very close to that. So that might be our next conversation, in a month or so from now. But I do think we'll see another vaccine show up.
Yeah,
soon.
That's true. Well, there is the Johnson & Johnson vaccine that's going into I believe that's the one you're referencing. They're going into their final trials there, and they expect to produce data to the FDA by the end of the month. I think the end of January. Right. Now that's a 1-dose vaccine. So that
correct. So it works a little differently, and as a 1-dose shot.
That'll be interesting to talk about too. Is there any conspiracies you want to dispel now that I've got you? Because I have had a few people write to me about some things. They're concerned about what that the vaccine might do to them long term, things that maybe they've read on memes or things that have been passed around on social media.
One of the biggest ones I hear from a lot of healthcare workers are female and they are of childbearing age. And one of the most dangerous forms of disinformation I've seen float around out there is this idea that somehow the vaccine is going to cause them to be infertile, to not be able to have a baby. And I just want to make sure everybody understands there is zero data for that. There is zero data for that. And the American College of Gynecology is very supportive of, considering the vaccine, at least with, understanding that, there's not much data for pregnant women, but there's no mechanism, no way that this would happen. And I just want to make sure people understand that, because I think that's a very damaging form of disinformation out there, because it's a group of people who need to be vaccinated, because a lot of our frontline healthcare workers are young women.
Anything you want to say about children and the vaccine?
Well, we don't have a lot of data yet on children, I think we'll get there eventually. Right now, it's just a dataless. We call it a dataless space. It's interesting because it brings up pregnant women, right now, I think most pregnant women, could consider having this vaccine. It's not contraindicated. It's obviously your own decision with the pregnancy. There are no pregnant women enrolled in the trial. So what I mean by your own decision, it's reasonable to say, look, there weren't any pregnant women in the trial. I'm not comfortable with it. But the American College of Gynecology is supportive of this. The CDC is supportive of this. And what's interesting is you will probably create antibodies that would be passed on potentially to a childbirth or even through breast milk.
Which, again, would completely dispel that rumor, that conspiracy.
Right.
Look, wait and see approach in a lot of things with distribution here. Dr. Wilson feels good about it. And remember, abcactionnews.com, the Rebound section, also the coronavirus section for all things you need to know about vaccine distribution in your county. Always happy to bring you the Rebound Tampa Bay podcast ad-free on Apple, Stitcher, and Spotify. We also link up a video version of this podcast in several places. You can find it on our streaming news channel, our ABC Action News app, right on your phone, on any device. You can watch the video version. I also put it up on my Facebook page. That's James Tully, WFTS. As always, I am here for you. If you have any questions, send me a message. I will get back to you. I get back to everybody. Thank you very much for listening. This has been another episode of the Rebound Tampa Bay podcast.